Okay, so thanks very much. What I'm going to talk about today is sort of type 2 diabetes, what it is, and how to understand it so that you can sort of reverse it. And we'll sort of get back to some basics. This is a bit of a more technical talk, but there's two sort of phases of type 2 diabetes that people talk about. So there's the sort of insulin resistant stage at the beginning, and this is the Whitehall study, which took people with type 2 diabetes and they had archived blood for sort of 14 years before the diagnosis of type 2 diabetes. And they looked at these people and said, well, what's different about them compared to the people that didn't get type 2 diabetes? And what you can see is that the fasting glucose in the people who didn't have diabetes, it sort of stays stable because they never got the type 2 diabetes. But in the people who did get type 2 diabetes, there's sort of two slopes. You see the first initial part from about 12, 13 years up to about 2 years prior to the diagnosis. What you see is this stage of insulin resistance. And that's where the fasting glucose starts to go up a little bit, but the body produces more insulin. So you have both hyperinsulinemia as well as insulin resistance, and that keeps the glucose down. At a point just before the diagnosis of type 2 diabetes, or just before, the insulin secretion doesn't keep up. And mind you, it's not that insulin level are low. They're actually very high, but they're not as high as they used to be. And that's called beta cell dysfunction. And as you lose that sort of compensation, blood glucose goes up very high. And that's when it goes and becomes something called the diagnosis of type 2 diabetes. And that's called beta cell dysfunction. And that's thought because the beta cell in the pancreas is thought to sort of burn out. And so you can see if you look at the fasting insulin that this is really a continuum. That is for going from a normal lean person to obesity to type 2 diabetes and so on, you have higher and higher levels of insulin. So that's the hyperinsulinemia, which is really the same thing as the insulin resistance. And this is just to show you what the insulin levels do as you progress along that sort of continuum. That is, this is the normal situation where glucose and insulin are sort of in lockstep. And then as you go from obesity to early diabetes, what you see is that there's very high rise in insulin in these dark circles. And that's what keeps the glucose from going up too high. As this insulin starts to fall, it's still higher than normal, but because there's less of this compensation, the glucose goes up. And that's why some people used to say that this was a chronic and progressive disease because they said, well, the pancreatic beta cell is burning out, and as it burns out, it just keeps getting worse and worse. And so therefore, it's chronic and progressive. This is actually just a big lie. It's not actually true. And everybody who deals with type 2 diabetes knew it wasn't true. And yet, up to about 2018 or so, the American Diabetes Association would tell people that this is the case. That is, for most people, type 2 diabetes is a progressive disease. But it's clearly not true because if you think about it, everybody, patients, nurses, doctors, everybody knew that if you lost weight, that type 2 diabetes would usually get better or even go away completely. So it's actually a disease that's reversible. It's just that we weren't using the right treatments. That is, we weren't getting people to lose weight, and therefore we weren't influencing the natural course of type 2 diabetes. And in fact, that's why they had to change. In 2021, the American Diabetes Association then had criteria for remission. And that meant that if this was in fact a reversible disease, something that hadn't really been in the sort of mind set of doctors until about 2020, 2021, something like that. So it's very, very new, this idea that you can reverse type 2 diabetes. I've been actually talking about it since about 2013, 2014. Diabetes Canada, of course, up until 2023, kept telling people that it was a progressive lifelong disease. So the point is that this is actually a disease that can be reversed. And it's very, very easy to prove because there's lots of treatments that reverse type 2 diabetes. The first one, for example, that that's been well studied is bariatric surgery. So if you have type 2 diabetes and you do bariatric surgery, this was from 1992, so that's like 30 years ago. we had data that the blood glucose would fall almost immediately, and some of the responses were extremely long-lived. So if you do, weight loss surgery, then before a significant weight is lost, like within a month, the blood glucose would simply just go right down. And sometimes it stayed down. And of course, this was well established in 2012, so more than 10 years ago. What you see is that the Roux-en-Y bypass and sleeve gastrectomy would cause you to be able to stop most of your diabetic medications. The body mass index went down compared to medical therapy where there was no change. So as you get off of the diabetes and your A1C goes down, of course, that is remission as defined by the American Diabetes Association now. So you could put this disease into remission. But it wasn't through taking those medications, the insulin and so on. Without surgery, if you just do a gastric banding, you could see the same thing. So you could reverse that type 2 diabetes. If you look at the fasting glucose before surgery and after surgery, you could go right down. And it would go back into the normal range. And this has been well known. Bariatric surgery was one way you could certainly do it. Diet also actually had a slightly better effect. So if you look at some of the diets that they put people on before bariatric surgery, which was a very, very low calorie, low carbohydrate diet, people actually lost more weight even compared to the surgery. And their blood glucose actually dropped more than surgery. The second thing is fasting. So fasting is simply a period of time where you don't eat. And this is not a new treatment. In fact, Elliot Jocelyn talked about it in 1916. So that's more than 100 years ago. And he said that, in fact, it was so effective that he wrote in 1916 that the treatment of diabetes with temporary periods of undernutrition, it's so effective with fasting that probably didn't even need a study. They said it would be acknowledged by all. Of course, at the time, they didn't differentiate between type 1 and type 2 diabetes, which is very important because, of course, type 1 diabetes is very, people are very underweight. But nevertheless, this was a case report I wrote where you could use intermittent fasting for type 2 diabetes. And in fact, people would reverse their type 2 diabetes very quickly. Not very hard to understand. If you don't eat, you'll lose weight. As you lose weight, your diabetes can go away. In fact, this was a number of people who they had profiled on that. And you can see as they lost weight, that type 2 diabetes got better. And intermittent fasting could play a big role in that. Very low carbohydrate diets can do exactly the same thing. And in fact, this has been well established. So this is from the American Diabetes Association, published in 2020. This is this sort of nutrition consensus report. So their scientific report from the American Diabetes Association. And what they said is that if you lower the overall carbohydrate intake for individuals' diabetes, that gives you it has the most evidence. That is, it's not some kind of a fad diet. Reducing carbohydrates for type 2 diabetics has more scientific evidence than any other diet. That's basically what they're saying. Again, not very difficult to understand because we know that carbohydrates as a macronutrient raises blood glucose more than fat or proteins. Why? Because carbohydrates are glucose. So if you look at bread and rice and potatoes, they're long chains of glucose. And if you eat glucose and break it down quickly and absorb it, your blood glucose goes up. So not very hard to understand why cutting down those foods that raise your blood glucose might improve your blood glucose. It's very, very simple. And of course, it works. And that's what the consensus report basically said. Dr. Unwin, of course, published his own experience looking at this over 6 years. And what he found was that if you simply advise people to do a low carbohydrate diet, he actually put almost half of his patients into a drug-free remission state. If they had pre-diabetes, it could be up to 93% of them into a drug-free remission state. And there was no sort of threshold. That is, the people with the highest A1Cs benefited just as much as the people with the lowest A1Cs, that you could push them all down. So what we see is that there are treatments, in fact, that cause reversal of the type 2 diabetes. That is bariatric surgery, intermittent fasting, low carbohydrate diets. And yet, if you look at a lot of the way that we treat diabetes, we know that things get worse. If you treat people a lot of insulin, sulfonylurea, some of the old drugs, if you use a lot of low-fat, high-carbohydrate diets, again, if you're eating a lot of carbohydrates, you're eating those very foods that will raise your blood glucose the most. So in those cases, we see that the type 2 diabetes gets worse. And yet for decades, the current treatment strategies were all directed towards here instead of what we knew could actually reverse type 2 diabetes. So why were those treatments successful? And you have to understand two sort of key concepts, that is underfill versus overflow, and looking at the blood glucose versus the glucose in the whole body. And let me explain what I mean. So this is the way a lot of people think about type 2 diabetes and insulin resistance. That is, this is a schematic. You have a cell here. You have a certain amount of glucose in the cell. You have glucose in the blood, and you have insulin. So it's basically like a lock and a key. If you have insulin, it basically goes to the insulin receptor and acts like a key, opens up a gate, which is the GLUT4 receptor, and then GLUT4 allows the glucose from the outside to go in. So it's, this is sort of like a gate. Insulin acts like a key. You open the gate, the glucose is now able to go inside. Insulin resistance is where you see that there's the normal key, which is the insulin, plenty of keys, and there's a lot of glucose on the outside, but for some reason, it's not being able to get in. And the question is why? Where is this malfunction? And the idea is that insulin resistant is something like maybe there's like a piece of gum in the lock, right? And so therefore, if you have the key, it still doesn't open the gate, and therefore all this glucose goes outside. And then, so you get this insulin resistance, and then this causes you to produce more insulin in order to try and brute force this glucose into the cell, because inside the cell, you have a situation of internal starvation. Because the glucose is outside, it can't go inside. Well, you're starving inside. There's no energy. But after 50, 60 years of research, people couldn't agree what's causing this insulin resistance. Like, what is it? Is it some kind of toxin? Is it something environmental? Is it genetic? What is it? It can't be genetic, because we know that the incidence of type 2 diabetes is rising very quickly. So the question is, what is causing this? And is this the right framework to be thinking about type 2 diabetes? If you think about this internal starvation, this is a situation you see in type 1 diabetes. That is, if you can't get insulin, if there's no insulin, then the glucose cannot get into the cell is starving, so you get very, very thin. So no matter what you eat, your body just keeps losing weight until you die. And if you treat these people with insulin, then they gain weight again. However, this is not what a type 2 diabetic person generally looks like. In fact, they look like this. So it's really hard to argue that this is a state of internal starvation, that their body is somehow undernourished because you can't get glucose into the cell for energy. So there's a different way to think about it, right? So this is normal insulin metabolism. So again, you have glucose, you have insulin, and this is a normal amount. We know that there's a lot of insulin and there's a lot of glucose. So is it because this is blocked? That's the internal starvation paradigm. Or is it, in fact, a situation where it's overfilled? So you can get the exact situation on the outside, lots of glucose, lots of insulin, but the reason that the insulin can't go in is because you just have all this excess intracellular glucose. So this gate is open, but the glucose can't go in because it's already full. So it's no different than if you have a suitcase, for example, and once you fill it up, you can't put any more in. The problem isn't with the suitcase or the lock or whatever, it's just full. But the implications are very different, because if you have an internal starvation situation, the solution is to give more insulin. In this situation, you have too much insulin acting for too long, which has led to this overflow, and the solution is less insulin. So it's a very, very important thing to understand in order to treat it. So this is the suitcase, and it's also no different than if you have a, say, a subway or a train. So insulin is like the people, it opens up the door, right? The train pulls into the station, insulin opens up the door, the glucose, which is on the platform, then should go inside. If you see all these people on the outside, it could be that the door's not opening. That's the internal starvation theory. Or it could be that it's full and insulin keeps trying to push more people in, but at some point it simply can't do so. This is very important because if the problem is that the door is not opening, then you're going to try and open the door. If the problem is that there's too many people, then you need to offload the people. So very, very different solutions. So the question is, which is more likely? You have this sort of mystery villain, which is causing insulin resistance, which is causing hyperinsulinemia. This is the underfill internal starvation paradigm, right? Your cell is starving. So, this is something which is causing, we can't find. It's been eluding these scientists for decades, but yet causing this worldwide epidemic. It's also going to predict certain things. That is, you're not going to have fatty liver. In fact, people are going to be very skinny, and losing weight is not going to reverse the disease at all. So clinically, this does not fit at all the situation that we're seeing. The phenotype is completely wrong. The other possibility is that this is an overflow problem. That is, the glucose is overflowing the cell, and that's why you have all of this. And what this means is that the hyperinsulinemia is the primary problem, right? And which is causing the insulin resistance, which is causing more hyperinsulinemia, which can be then traced to dietary changes. That is, increased meal frequency, higher carbohydrate intake. And this is also going to make certain predictions. That is, you will have fatty liver. You're going to have people who are overweight or obese. And if you lose weight, that is, burn off all this excess glucose, then you're going to reverse the disease. And that is exactly what we see. So this overflow paradigm of insulin resistance, hyperinsulinemia is very important to understand because it sets you up to understand why certain treatments, in fact, are beneficial and certain ones are not. And you can see immediately why bariatric surgery, fasting, and low carbohydrate diets work, whereas giving more insulin, giving sulfonylureas do not. And this is not new. In the Banting lecture in 2011, they talked about it. So the Banting lecture is the American Diabetes Association's highest scientific achievement award, and they talked about it, hyperinsulinemia. Is that in fact causing the insulin resistance, or is it the consequence? And the answer is, of course, both are possible. But, if hyperinsulinemia, too much insulin, causes the problem, then what you're going to predict is that giving more insulin to control the blood glucose will not improve things. And remember, this is how we treated people. If you come in with type 2 diabetes, your glucose is high, you give people insulin. But if they already have too much insulin and you give more insulin, then it's not going to work. Just like if you have hyperthyroidism, you're not going to give more thyroid disease. And lowering the blood glucose instead of the whole body glucose, that is all that glucose that's inside the cell, will not improve outcomes. That is, you can give insulin, you can take the glucose and shove it into the cell, but that won't improve things if hyperinsulinemia is the primary problem rather than the consequence. So this underfill treatment paradigm says if you give more insulin to a hyperinsulinemic patient, you can move the glucose from outside the cell inside the cell. But the problem is that it doesn't really help you. There's multiple studies over the last 10, 15 years which show you that if you control the glucose very tightly with more insulin, it doesn't improve outcomes. This is, almost 28,000 people with type 2 diabetes. And if you're on oral hypoglycemics, what you see is that, this is your survival, basically. And, it's lowest at a hemoglobin A1C of 8%. If you have a A1C of 10, 11%, it's quite bad, right? Same as if you're on insulin, it's bad. But if you have a low A1C, it's really just as bad because there's no benefit. If you're taking glucose from outside the cell and just shoving it into the cell, well, you haven't gotten rid of the glucose. The glucose is still inside your body, causing all the damage to your heart, to your kidneys, and so on. You never got rid of it. Therefore, you're not going to see any improvements. And that's exactly what we found in the Accord study, which is that randomized control trial, where we simply randomized people to tight control versus not tight control. And that was at a time where we gave people lots of insulin. Yes, you could drop their A1Cs from 7.5 to 6.5, but in fact, they didn't have better outcomes. In fact, they may have actually have worse outcomes. It may have increased the risk of death, hazard ratio of 1.22. And that wasn't just that study. The advanced study said the same thing. Death from any cause was no different, major macrovascular events. So the underfill sort of internal starvation paradigm simply did not work. So the overflow treatment paradigm is completely different. If hyperinsulinemia is the problem, then you need treatments that lower the insulin, and you got to get rid of the glucose. You got to get that out of the body, not just the blood glucose, right? So this is like, suppose you have garbage, right? But instead of throwing it outside and into the dump, you just put it under the bed. Well, that doesn't get rid of the garbage, right? It's still there. It's still going to stink. So same thing with the glucose. If you simply take the glucose that's in the blood and shove it into the liver, well, it's not going to help. So that's the whole problem. So how are you going to lower insulin? How are you going to get rid of this glucose? Well, luckily we have two new drug classes that do that. The SGLT2s, for example, they help your kidneys dump that glucose. And by doing so, they lower the insulin, right? Because if you have less glucose, you need less insulin, right? Insulin is going to push that glucose intracellular. And of course, this is exactly the benefits that we're finding in terms of end organ damage. The EMPA-REG, for example, looked at empagliflozin, and they were able to lower the A1C, but not a lot. You went from 8% to 7.6%, so not a very good benefit. But look at the all-cause mortality. You reduce the all-cause mortality by almost 32%. There's also the new GLP-1 agonists, which again are very, very powerful agents to reduce eating. And when you do that, insulin goes way down because people eat so much less, almost 700 calories less. And their insulin levels go down because they're eating less. So the whole point is that while you can certainly drop their weight with semaglutide, it also reduces end organ damage like massively. Like, so if you look at stroke, for example, you reduce it by 26%. Nephropathy, you can reduce it by like 36%, hazard ratio of 64%. So semaglutide having really very important benefits. And what it goes to show you is that is probably treating the disease process. So lowering the blood glucose, right? Moving the glucose from the blood into the body is only symptomatic treatment. Okay, so we mistook the disease of diabetes and we said it's a symptom. The symptom is high blood glucose, and it's just like if you have an infection and it's caused by a bacteria, you need to treat it with an antibiotic. It causes a symptom of fever, which you treat with acetaminophen or Tylenol. If you treat the fever, it doesn't it doesn't alter the disease process. It doesn't change anything. Same thing with type 2 diabetes. It's the type 2 diabetes that causes the high blood glucose. So you can certainly treat the high blood glucose with insulin and sulfonylureas, but you have to understand that that's not the disease. That's symptomatic treatment, and symptomatic treatment doesn't do anything in the long run. Type 2 diabetes, if it's caused by hyperinsulinemia, you need to lower the insulin. And you can do that with drugs, but again, more effectively, you can do that with dietary changes. And that's where SGLT2s come in, GLP-1s, but also low carbohydrate diets, and also intermittent fasting. Because if you look at this graph where we look at type 2 diabetes reversal, we have bariatric surgery, fasting, and very low carbohydrate diets. What do they have all in common? Well, the ones that make it worse increase insulin, and the ones that make it better decrease insulin. So it tells you that the part of the pathophysiology of the type 2 diabetes is not just the high glucose, it's the high insulin. And treatments that are going to treat the sort of root cause are going to be able to benefit you. So type 2 diabetes is a disease of too much insulin. Now, the question is the pancreas actually burned out? And that's really important to know, because if it is, then there may not be any treatment that you can do. So there's this Counterpoint study done a few years ago. And what they did is they took people and they treated them with very low-calorie diets, and they were able to get the blood glucose right down. And what they saw is that the fat in the liver, this is the triglycerides in the liver, decreased. So this is people without type 2 diabetes. And what you see is that as you lose weight, the amount of fat in the liver goes down. And the insulin sensitivity tends to also improve. So this is type 2 diabetes. This is hepatic glucose production. You can see that it's too high in type 2 diabetes compared to the normal. But as you treat them, it actually normalizes. You'll see the same thing in terms of pancreatic fat. So in people with type 2 diabetes, they have more triglycerides in the pancreas compared to the controls. But over time, you can actually reverse that to get it lower. And this actually restores the beta cell function. So this is the insulin response of the pancreas. Remember, the pancreas is producing insulin. And one of the things that people said is in type 2 diabetes, you're not producing enough insulin. Well, that is actually completely reversible. So it turns out that the pancreas is not actually burned out. It was probably just clogged with fat. And as you lose the weight, as you get the insulin down, the hyperinsulinemia, the pancreas actually starts to recover. So this is the twin cycles hypothesis of type 2 diabetes, and it's sort of important to understand this. I'll go through this simply. So what you had is a diet which caused sort of high insulin levels over a long period of time. Insulin, of course, is a disease, is a hormone that tells the body to store energy. So it leads to fatty liver, which leads to hepatic insulin resistance, right? So that's the overflow phenomenon, right? So insulin, if you're eating lots of carbs, you got lots of insulin, and you're constantly filling up that cell with glucose, you're going to have fatty liver, which is going to lead to the insulin resistance because of that overflow phenomenon, which is, of course, going to lead to higher insulin levels. So that's just the first cycle. You have hyperinsulinemia, hepatic steatosis, insulin resistance. But there's a second one. So as the liver starts to fill up with fat, it actually starts to get rid of that fat because it doesn't want to hold on to it. So it pushes it out. And this is with the VLDL and triglycerides, and it gets taken up by the other abdominal organs, which leads to this abdominal obesity, but you get this fatty pancreas as well. Because the pancreas is getting clogged, there's this reversible beta cell dysfunction, which leads to the high blood glucose, right? Because as you're not pushing out as much insulin, you're going to allow that your blood glucose levels are going to go up. And that's what's going to lead to this high insulin again. But what's important is that the high blood glucose, when it exceeds the renal threshold of glycosuria, the body is going to start to dump out the glucose out of the urine, which is going to cause glycosuria, which is going to cause the symptoms of type 2 diabetes. But you have to understand that that's actually a protective mechanism. If your body is dealing with too much glucose, this beta cell dysfunction is allowing your body now to dump out the glucose. So it's actually a natural solution to the problem. Yes, there are side effects of it, lots of symptoms and so on. And in fact, that's what we do with the SGLT2s, is enhance the body's own protective response to the excess load of glucose, and the body just dumps it out. So if you think about the disease from a hyperinsulinemia standpoint, not the hyperglycemia standpoint, and you focus on lowering the whole body glucose, not just the blood glucose, you can see that there are different drugs, such as the neurodrugs, the SGLT2s, the GLP-1s, which are going to be good because they decrease insulin in a disease where insulin is too high, which is going to cause weight loss. And what you see is very impressive cardiovascular outcomes. Blood glucose, it's okay. The SGLT2s are okay. They're not great. You can do much better with insulin. There's sort of the bad ones, which don't do anything, because remember, metformin and DPP-4s, they don't actually get rid of the glucose. They just move it around. So they move it from the blood into the body, which is like taking garbage, instead of throwing it out, just putting it under the bed. You're just moving it around where you can't see it. So it's sort of neutral in terms of insulin effect. It's neutral in terms of weight. And it's got pretty good effect on blood glucose, but it doesn't really get rid of the entire amount of glucose in the body. And then you have the really ugly ones like the insulin and so on, which is going to increase your insulin, which is going to cause you to gain more weight and generally increase your cardiovascular events, which is bad because it's going to cause weight gain. And patients instinctively know this, of course, because if you have somebody with type 2 diabetes and you start treating them with insulin, well, what happens? Well, you treat them with insulin, they gain weight. As they gain weight, their type 2 diabetes gets worse. As it gets worse, you can use more insulin, which is going to cause them to gain more weight. And then you simply spiral down out of control. So the whole point is that the treatment paradigm of treating a hyperinsulinemic patient with more insulin is not correct. It's like giving alcohol to an alcoholic. It might improve the symptoms temporarily, but it's not going to cure the alcoholism, right? Same thing with the insulin. It's like you can get the blood glucose down, absolutely, but that's not the disease. That's the symptom. You're making the disease of hyperinsulinemia worse. And the whole point is that you don't need drugs. There are certainly drugs that can help you with it, the SGLT2s, the GLP-1s, but you don't need the drugs to do that. And that's where the low carbohydrate diets and intermittent fasting are very beneficial. So those ones are very easy to understand. It's the diet. And if you want to think about it in terms of body glucose, think of it like a barrel, right? What's happening is with the diet, you're putting in the glucose into the body, and that's not a bad thing. This is energy for the body, and you'll use it. So this is like the tap at the bottom. So if you exercise for your normal basal metabolic rate, you're going to use it. The problem is that over time, if you overflow this barrel with too much glucose, well, all you have to do is shut this off. That's the most important thing, which is either, through cutting down the carbohydrates, which are glucose, remember, so proteins and fats are not glucose. They're triglycerides and amino acids. They're not glucose. Or you could do intermittent fasting, which cuts all of them down. So the whole point is that type 2 diabetes is a reversible disease, and the implications are quite profound, because if you don't have the diabetes, then you don't have the nephropathy, you don't have the ulcers, you don't have the retinopathies, the strokes, the cancers, and you can actually reverse this without any kinds of drugs or surgery, and there's actually no cost. You just have to change the diet and do the intermittent fasting, and that's really the promise that we have going forward. We have this terrible disease that has so many consequences for people, and yet we can actually change this. And the power to do that is actually within our grasp. It actually just requires a change in our knowledge, a change in our practice, and then we can do something about this. Thanks very much.